Okay, distal forearm fracture are common in children, typically occur after a fall on outstretched hand. Patients have pain, swelling. Patients have pain, swelling, and limited range of motion of the wrist because the periosteum surrounding the bone is thick. Because the periosteum surrounding the bone is thick and strong, and the fracture may involve only one side of the body cortex rather than extending through the width of the bone. This is known as green streak fracture. As seen on this patient's X-ray, the opposite side appears to have deformation or bend without a break in the cortex. Prompt reduction, if displaced, and immobilization of the forearm is required for green streak fracture because they are considered unstable due to potential for refracture or further displacement if improperly treated. Repeat X-ray should be performed prior to cast removal to confirm bony union. Once the fracture is fully healed, no long-term complications are expected. A fracture that interrupts blood supply of the bone can lead to avascular necrosis. This condition is most commonly seen in femoral neck fracture and is unlikely occur to a green streak fracture. Chronic osteomyelitis chronic osteomyelitis is a potential complication of an open fracture in which disruption of the skin can introduce bacteria to the injured bone. This patient has no loss of skin integrity, making infection unlikely. And growth arrest caused by fracture involving the growth plate phases can lead to limb length discrepancy. In contrast, this child has a diaphyseal fracture. This this patient has non-displaced stress fracture of the second metatarsal. Stress fractures are caused by repeat tension or compression without adequate rest and may commonly occur in military recruits and athletes who suddenly increase their physical activity. The second metatarsal, which is subjected to significant extreme loading during gait, is most commonly involved. Typical findings include subacute activity-related pain, which may progress to wrist pain and point tenderness over the fracture. Diagnosis is primarily based on clinical findings. X-ray is frequently normal within the first 2 weeks if positive findings are either hairline lucency or a local periosteal thickening. MRI, CT scan, and scintigraphic bone scan are more sensitive, especially for early fracture, but are not usually needed unless there is a high risk of malunion. fifth metatarsal. Fracture of the second, third, and fourth metatarsal are managed conservatively, as surrounding metatarsal act as a splint, and non-union is uncommon. Initial intervention includes cessation of the repetitive activity, marching, running, simple analgesic, acetaminophen. Some expert advise NSAIDs due to a possible delay in the healing times. Patients who continue to have pain, patients who continue to have pain despite activity restriction may additionally be managed with a white hard sole podiatric shoe. Yes. Clinical features of the stress fracture: repetitive activity, running, military, marching, abrupt increase in physical activity, volume, intensity, low bone mineral density from inadequate nutrition, malabsorption, and estrogen deficiency in women, functional hypothalamic anemia. Clinical presentation: insidious, gradual, worsening, onset of localized pain, gradual worsening onset of localized pain, point tenderness at fracture site, usually negative X-ray in first 2 to 3 weeks, management analgesia and reduced weight bearing, referral on orthopedic surgeon, for high risk fracture, anterior tibial cortex, fifth metatarsal. This patient this patient has localized pain and paresthesia in the lateral thigh consistent with myalgia parasitica. Myalgia parasitica is caused by compression of the femoral cutaneous nerve, where it passes under the inguinal ligament into the thigh. Patient experience symptoms in the distribution of the nerve but has no weakness because the nerve contains no motor fibers. Myalgia paresthetica is often caused by tight clothing or belts or by abdominal straining. The risk is increased in patients who are pregnant, obese, and have diabetes mellitus. The diagnosis is made clinically. No imaging is needed because myalgia paresthetica is a benign, self-limited condition. Conservative treatment, avoiding tight garments, weight loss, weight loss, and is usually adequate and improves symptoms more than 90% of cases. Patients with persistent symptom may respond to anticonvulsant and local nerve block. No. Okay. This patient has typical characteristics of osteoarthritis, including advanced age, obesity, chronic joint pain that is worse after activity at the end of the day. Osteoarthritis predominantly affects the large weight-bearing joints of the lower extremity, hips, knees, and the small peripheral joints in the hands and the cervical and lumbar spine. OA is due to degeneration of the articular cartilage and is usually idiopathic phenomenon of aging, although it can occur due to acute or chronic joint injury, certain systemic disease, hemochromatosis. Examination findings suggesting of osteoarthritis in the knee include periarticular bony hypertrophy and tenderness, limited range of motion exercise with crepitus and pain, and small joint effusion without erythema or worm, varus or valgus angulation, and popliteal cyst behind the joint. X-ray can confirm the diagnosis. Arthrocentesis show clear fluid with few inflammatory cells and can be helpful in evaluating patients with acute symptoms. Lab testing include inflammatory lab testing include inflammatory, ESR, CRP, and serologic rheumatoid factor markers is normal. And it is not Payne-Ansar's pain syndrome. It is characterized by pain and tenderness over anteromedial tibia distal to the joint line. The risk is increased in obese patients, but the symptoms typically evolve over months, over weeks to months, not years, and the pain is often worse overnight in the morning. Because the Payne-Ansar is extra-articular process, there is no associated crepitus or effusion. Yes, like osteoarthritis, medial meniscus injury may display crepitus and a small effusion on examination. However, although older patients may have chronic degenerative tears, meniscal tears are more common following acute athletic twisting injury in younger patients. Also, patients typically experience locking or catching of the knee during extension of the knee during extension. Okay. Okay, these patients, hip arthalgia, abdominal pain, and lower extremity petechial rash are consistent with HSP or IgA vasculitis, the most common vasculitis in children. Diagnosis of HSP is clinical, palpable petechiae purpura without thrombocytopenia or coagulopathy as seen in this patient, and is required diagnosis plus two or more than two of the following arthritis or arthalgia, which may commonly affects the lower extremity and may cause refusal to walk in the young children. Colic abdominal pain due to intestinal edema, which can lead to nausea, vomiting, gastrointestinal, which can lead to nausea, vomiting, and gastrointestinal bleeding and intussusception, and renal disease, hematuria, or proteinuria. In pediatric disease, classic finding as seen in this girl, no additional diagnostic testing is required. In adults in whom IgA vasculitis is rare, and in children with an atypical or incomplete presentation, skin biopsy is the next step. Skin biopsy is the next diagnostic step, revealing neutrophilic infiltration with IgA C3 fibrin deposition with post-capillary venules. Elevated serum IgA, low C3 may be seen. Elevated serum IgA and low C3 may be seen in some patients, but those tests are non-specific. Those tests are non-specific and of little diagnostic use. Yes. Renal disease in HSP may not be initially evident. Renal disease in HSP may not be initially evident as seen in this patient with a normal urine analysis, but it can develop months after symptom onset. Serial screening urine analysis should be performed, but renal ultrasonography is not typically indicated in HSP management.
So 68 woman. The pain has medication number.
Is it Paget's? Okay. This patient has typical features of Paget's disease of the bone, including bony pain, deformity, and mixed lighting and sclerotic lesions on X-ray. Paget's disease is characterized by Paget's disease is characterized by disordered osteoclastic bone resorption of uncertain etiology. Paget's disease can cause focal enlargement, weakness, or fracture of the bone. Bowing of long bone, bone pain, arthritis in adjacent joints are common. Involvement of cranial bones may cause frontal bruising, headache, cranial nerve dysfunction, and hearing loss. Due to in, due to increased turnover, due to increased bone turnover, serum ALP is elevated, often more than 10 times in the upper limit of normal. Paget's disease is most common cause of asymptomatic elevation of ALP in older patients and is often discovered on routine lab testing. Urine hydroxyprotein is derived almost exclusively from the breakdown of collagen, and levels will be increased in Paget's disease as well. Urine calcium is increased. However, serum calcium and phosphorus level will be normal in the absence of other complicating factor, prolonged immobility, concurrent hyperparathyroidism. Okay. It happens suddenly, isn't it? Or it took time.
I mean, they said she.
So is it acute kidney injury? Next. Okay, wait. First diagnose. Wait. The skin of the hands is shiny and thickened. Thickened skin. What is your diagnosis? Yes, scleroderma, systemic sclerosis, and systemic sclerosis, renal crisis. Yes, AC inhibitor. Yes, AC inhibitor and calcium channel blocker like no dihydropyridine calcium channel blocker, verapamil diltiazem. These can be used. I'm missing the particular words. Okay. This woman with shiny, thickened skin. This woman with shiny, thickened skin and multiple telangiectasia likely has systemic sclerosis scleroderma, which is characterized by widespread fibrosis of multiple organ system. Other common manifestations include swollen digits, ulceration at the digital tips, and Raynaud's syndrome in association with severe hypertension and acute renal failure. These presentations such as scleroderma renal crisis. Scleroderma renal crisis is a life-threatening complication of the systemic sclerosis that may be initial manifestation of the disease. Renal vascular injury due to a part of the collagen deposition leads to ischemia, which results in activation of the renin-angiotensin system. These raises blood pressure and further damages the renal vasculature, causing a vicious cycle of worsening hypertension and renal dysfunction, elevated creatinine edema, hypertensive emergency with an end organ dysfunction, encephalopathy, retinal hemorrhage is common, thrombocytopenia, and microangiopathic hemolytic anemia can be seen. Urinalysis is usually normal but may show mild proteinuria, as seen in this patient, and casts are unexpected. The mainstay of the treatment of scleroderma renal crisis include AC inhibitor, which reduces the RAS activity, improve renal function and blood pressure. Short-acting AC inhibitor, typically captopril, are used because they can be rapidly titrated, up titrate, up titrated, and elevated serum creatinine is not a contraindication for AC inhibitor in this population, and slight elevation in creatinine are common during drug initiation. Beta blockers, is more known, are usually avoided in systemic sclerosis and due to increased risk of vasospasm, worsening Raynaud's phenomenon, and hemodialysis may be required in some patients with scleroderma renal crisis. However, this patient has no urgent indication, that is hyperkalemia, volume overload with respiratory impairment. ACE inhibitors improve renal function and would likely prevent the need for dialysis. Sorry. Glucocorticoid methylprednisolone can cause salt and water retention, can lead to hypertension. They are a major risk factor for the development of scleroderma renal crisis and should be avoided in patients with systemic sclerosis. And transdermal clonidine can serve as antihypertensive, but is typically slower acting and cannot be rapidly up titrated. In addition, it would not treat the underlying RAS hyperactivity. What is your diagnosis? No. Look, wait. He has done arthosynthesis. By doing arthosynthesis, we see the crystal. There are two sort of crystal arthropathy. It is a primary hyperparathyroidism and and it and it is pseudo gout, a complication of hyperparathyroidism. Okay, so this patient has a symptomatic hypercalcemia, fatigue, constipation, nephrolithiasis, lightly calcium stone, likely calcium stone, suggesting primary hyperparathyroidism. He has non-acute inflammatory. He has acute inflammatory arthritis. Pseudogout is caused by calcium pyrophosphate dihydride (CPPD) crystal in the joint space and is a common complication of hyperparathyroidism with chronic hypercalcemia. Pseudogout is also associated with hypothyroidism and hemochromatosis. Pseudogout presents with acute pain, swelling, redness, a limited motion of the involved joint, with the knee most commonly affected. Synovial fluid analysis will show an inflammatory effusion. The rhomboid shape, positive bipharyngeal crystal CPBD, can be difficult to detect on synovial fluid analysis, but are diagnostic when present. X-ray are X-ray can be useful to diagnose pseudogout and typically reveals chondrocalcinosis. Okay, polymorphonuclear cells of the gram-positive cocci. Polymorphonuclear cells of the gram-positive cocci can cause septic arthritis. Although septic arthritis typically with acute inflammatory arthritis, most patients have recent or concurrent infection and likely have fever on presentation. This patient hypercalcemia makes pseudogout more likely. What is your diagnosis? Yes, VCF, vertebral compression fracture. And look at the age. Age is 67, so above 65, think about osteoporosis in men. This patient, this older patient has acute back pain consistent with vertebral compression fracture. Acute vertebral compression fracture commonly occurs from a minor trauma such as lifting, twisting, coughing, or falling from a standing height. Pain is usually located in the midline, although it can radiate to the flank or upper abdomen. Pain often worsens with movement, coughing, or straining and may persist at night. Examination typically demonstrate vertebral point tenderness, spinal cord or nerve root compression is rare. Patients usually do not have neurologic deficits. BCF is most commonly due to decreased bone density from osteoporosis. The risk is greatest in the postmenopausal women and men age more than 65, such as this patient. Other etiologies include osteomalacia, vertebral osteomyelitis, malignancy with bone metastasis, metabolic abnormality, and trauma. The diagnosis is usually established with plain X-ray of the spine. MRI or CT scan are also effective if the diagnosis is uncertain or underlying malignancy is likely. Imaging commonly identifies additional asymptomatic compression. Initial evaluation should also include studies to identify additional contributing factor, hyperthyroidism, hyperparathyroidism, vitamin B deficiency. DEXA scan should also be obtained to guide chronic management. Apophyseal joint arthritis can occur in spondyloarthropathy, ankylosing spondylitis, which can typically present with chronic progressive pain that is worse at night and with prolonged rest. Symptoms are usually begin at age less than 40. Degenerative disc disease can cause low back pain, but the pain is usually chronic, worsens with activity, and relieved with rest. Disc degeneration can also lead to acute disc herniation, but this typically presents with acute lumbosacral radiculopathy, pain radiating in a dermatomal distribution because most herniations are posterolateral, and vertebral tenderness is consistent with VCF. Ligamentum back sprain can occur following exertion. However, the pain is usually relieved with rest and tenderness and would be seen in paraspinal tissue rather than at the midline over the vertebra. Okay, Is it erythema nodosum? This I don't know. I am asking you.
Mm,
Okay.
Indeed.
Okay. This image depicts erythema nodosum, which is characterized by painful, which is characterized by painful subcutaneous nodule, which is characterized by painful subcutaneous nodule that are common, that are most common on the anterior lower legs, anterior lower legs. Arthalgia and malaise can develop alongside the nodule. Erythema nodosum is thought to represent a delayed hypersensitivity reaction to antigens associated with various conditions and is often relatively benign with self-resolution in several weeks. However, erythema nodosum can be an early sign of more serious disease. Identification of the cause may prevent morbidity. Disease associated with erythema nodosum include streptococcal infection, sarcoidosis, TB, endemic fungal disease, histoplasmosis, IBD, and Behçet's disease. The initial workup include basic lab CBC, liver function, renal function, anti-stabilizing O antibody, and TB skin testing. In addition, a chest X-ray should be obtained to assess for finding consistent with sarcoidosis, bilateral hilar lymphadenopathy, reticular opacities, and with TB, unlikely the absence of symptoms. The prevalence of sarcoidosis in patients with erythema nodosum is as high as 28% in some population. The absence of pulmonary symptom dyspnea, cough in patient does not rule out the sarcoidosis, as up to 50% cases are diagnosed by incidental chest X-ray finding prior to symptom development. Okay, yes. Common features of sarcoidosis: young adults, African American, constitutional symptom, cough, dyspnea, chest pain, erythema nodosum, cough, dyspnea, chest pain, extrapulmonary findings, skin lesions, anterior or posterior uveitis, Lofgren syndrome, parotid gland swelling. Imaging show bilateral hilar adenopathy, systemic pulmonary reticular infiltrate. Imaging lab hypercalcemia and hypercalciuria, elevated serum AC level. Pathology biopsy showing non-caseating granuloma that stain negative for fungi and acid fast bacilli. Lofgren syndrome, fever, fever, lymphadenopathy, uh, uh, fever, fever and bilateral lymphadenopathy, as far I remember. How alcohol? Why you picked alcohol? Steroid is one of the risk factor too. Okay. Okay. Yes. This patient has osteonecrosis of the femoral head, presenting with chronic joint pain and decreased range of motion. The diagnosis is confirmed on X-ray of flattening and patchy sclerosis of the femoral head. X-ray has low sensitivity and MRI can visualize the boundary. MLR, MRI can visualize the boundary between the normal and the ischemic bone may be performed if X-ray is non-diagnostic. Osteonecrosis is caused by disruption of perfusion. Disruption of perfusion due to macro or microvascular occlusion, endothelial dysfunction, or increased intraosseous pressure. Excessive alcohol use is a major risk factor. The risk is proportionate to the amount and the duration of the disease, with most cases occurring in individuals consuming more than 24 drinks per week, more than 400 ml, more than 24 drinks per week, or more than 400 ml per week, or more than 8 years. Alcohol-related osteonecrosis is likely due to fat embolism in the setting of hyperlipidemia, particularly hypertriglyceridemia. Additional contributing factors include adipocyte hypertrophy in the marrow with resulting venous stasis. Okay, yes. Autoimmune arthritis, primarily RA, can affect the hip and can cause chronic pain and loss of motion. However, monoarticular hip RA is rare and most patients have polyarticular disease. In addition, the typical X-ray findings of RA, periarticular bone erosion, and osteopenia, concentric loss of joint space are not present in this patient, and he has no erythema, worm, or swelling to suggest inflammatory synovitis. Human leukocyte antigen B27 serotype is a risk factor for ankylosing spondylitis and psoriatic arthritis. AS can affect the hip, but most patients have chronic back pain and sacroiliac pain. Psoriatic arthritis can present as distal small joint arthritis, mixed oligoarthritis, and spondyloarthropathy. Large joint monoarthritis is rare. Okay. Is it SLE? Mm, joint pain, thrombocytopenia, urine 2 plus protein, and erythrocyte is present. Is there anything you are thinking? Which vasculitis? Antihistone for wait, antihistone for drug-induced SLE. Yes, you can remember Dil Aha, like you understand the as you were studying with Pakistani people, Bangladeshi people. That's why Dil means heart, and Aha is antihistone antibody. So Dil Aha, you can remember it. DIL. You can say your tutor. Dil Aha. Dil means drug-induced lupus, and AHA is antihistamine antibody. Usually, we in lupus most of the time we actually think that it is ANA and this and that. Sometimes drug is the factor, and the drugs are procainamide, hydralazine. You know the drug. Okay, okay, sorry. I thought I have read all. Okay, this patient. While I am solving question, like after 5 to 10 question, I start dreaming. Okay, this patient, this patient has asymmetric. You never fall asleep in the exam hall, do you? But I have that experience, plenty of time. Okay, this patient, this is my problem. Even in my MBBS life, I never continue all the class because I am so drowsy. Okay. This patient has symmetric polyarthritis, pain, stiffness, tenderness associated with possible serositis, sharp chest pain. In the context of systemic feature, fatigue, mild cytopenia, leukopenia, thrombocytopenia, and protein losing, nephropathy, edema, proteinuria, microscopic hematuria. This presentation is suspicious for SLE. Initial evaluation or SLE should include complete blood count, renal function studies, urine analysis, and serum creatinine, serum complement level C3, C4. In addition, autoantibody studies are recommended to support the diagnosis, and antinuclear antibody titer is very sensitive for SLE and should be obtained in the first order test. However, ANA is not specific but can be elevated in other autoimmune disorders in up to 20% of the healthy women. If the ANA test is positive, more specific confirmatory tests such as anti-double stranded DNA and anti-Smith antibody can be obtained. However, these labs offer them as tests, reflex tests if the ANA test is positive. Okay. In this box, the most important like RA uh, sensitive RA is sensitivity is rheumatic factor and specific anti-CCP antibody, and for ASLE, ANA is sensitivity is higher, and a confirmatory test is anti-TS, anti-SMID. For drug-induced sensitivity is again ANA, but confirmatory is anti-histamine antibody. Diffuse systemic sclerosis anti-SCL70, and for limited variety anti-centromere antibody. And for polymyositis dermatomyositis, anti-Jo1 99 is positive.
This week.
Is it compartment syndrome?
Yeah.
Another complex topic. Compartment syndrome. Okay. This patient most likely developed compartment syndrome. Compartment syndrome, a condition in which increased pressure within the enclosed partial space limits perfusion of the tissue. The right forearm likely sustained ischemic injury from prolonged compression because the patient had lain unresponsive at the bottom of the stairs. On initial examination, mild swelling was noted, although compartmental pressure were measured as normal. However, over the next 12 hours, reperfusion due to relief of the compression and likely fluid resuscitation lead to increased edema, evidenced by tense swelling and pain, uh, grimacing on passive manipulation on re-examination. Because compartment syndrome can arise multiple hours after injury, serial examination, although serial examination sometimes with serial measurement of compartment pressure are initial for making a timely diagnosis. When a compartment syndrome is suspected, immediate surgical consultation for fasciotomy is indicated. If treatment is delayed, the increased compartmental pressure can eventually overcome perfusion pressure and can cause myonecrosis, neurologic damage leading to permanent disability or the loss of the limb. Okay, okay, can we take a break? You, you have done your breakfast? Okay, you can do your breakfast.